due to few technical problems, we will move on to the next. Our next presentation is a special session by our guest of honor, Dr. Nesreen Magdy. Dr. Nesreen Magdy, a consultant pathologist at University of College London Hospitals, NHS Trust in UK, and it is entitled Handling and Reporting of Testicular Resection Specimens. Dr. Nesreen, are you with us?
Yes, Dr. Muhammad, do you hear me?
Yes, Dr. Nesreen, I can hear you.
Okay.
You may start sharing.
Okay. And can you see my screen?
Yes, doctor, we can see your screen. That's great.
Okay. So, Assalamu alaikum. Good morning, everyone. First, I would like to thank Shefa Al-Orman Hospital and Dr. Muhammad Kamal for inviting me to speak today. And it's a real pleasure and honor to be part of this gathering again for this year. In my presentation, I will be discussing the testicular tumor specimens handling and reporting, and I will focus in detail on the critical points and will briefly touch on the items of less importance, and my aim to be as concise and to the point as possible and to stay within the allocated time and not to exceed my timelines like I did last year. So let's get started. So to begin, when handling a testicular tumor specimen, it's necessary to make sure that the essential required clinical information are listed on the request form or even accessible on the electronic file of the patient. And this includes, as with any other organ, the laterality, the specimen type, any history of prior treatment. But what is specific and unique for testicular specimens is the need to know the serum tumor marker levels that are usually done before the orchidectomy operation. And this will not only help in the diagnosis and the staging, it also can guide the way that we handle or handle the specimen or take our sections. For example, if the microscopic findings are showing tumor that's not matching tumor type, that's not matching with the elevated serum marker, so we have to go back to the specimen, take more sections in a trial to find out more tumor types. For example, in a pure seminoma, it's known that the only marker that can be elevated is the LDH, and other markers usually are normal, but there may be a slight elevation in HCG or alpha-fetoprotein, because it's known that 10 to 20% of pure seminomas may have sprinkled syncytial trophoblasts within the tumor, but it's usually less than 5% of the tumor volume, and the level of HCG never exceeds 500 in this case. So if it's more than that, this means that we missed a core U component, so we have to go to the specimen again and take more sections focusing on the hemorrhagic areas. And also for the alpha-fetoprotein, it may be slightly elevated, but not exceeding 20. If higher than that, this is considered by the clinician as mixed germ cell tumor, and this patient will opt for chemotherapy, and we have to go back and take more sections, or even through some markers on our tissue, like alpha-fetoprotein or glypican-3 in a trial to find a hidden yolk sac tumor component, which sometimes can be solid, mimicking seminoma. Next, moving to the specimen handling and block selection. It's very important to understand the normal anatomy of the testis to properly handle testicular specimens. So the testis has a fibrous layer, which is called the tunica albuginea, that it covers the entire testis, and this is enclosed within the two layers of the tunica vaginalis, which has a vestral layer and a parietal layer with a cavity in between. The testicular hilum is showing, it's formed of the retices, which are emerging from the testis towards the epididymis, and the hilar soft tissue is formed of connective tissue, fat, and blood vessels. It's important to notice that the hilum is not covered by tunica vaginalis. This is important when it comes to the staging, and also it's very important to know that the base of the spermatic cord starts above the level of the tunica vaginalis, and this is also very important when it comes to staging, as we will discuss later. On the histology level, this is the normal testis, and this is the fibrous tunica albuginea, and this is the adjacent epididymal head. This is the testicular hilum, which shows these ramifying, arborizing spaces, which are the rete testis emerging out of the testis towards the epididymis. And this is the adjacent hilar soft tissue that contains fat and blood vessels. This is the fibrous tunica albuginea, and this is the single layer of mesothelium of the visceral tunica vaginalis. If someone is unmuted. Okay. So can you mute yourself, please? Yep. Okay. So the types of testicular specimens we receive vary according to the clinical context. So the most common type is the radical orchidectomy, which is performed for most of the patients with clinical diagnosis of tumor, and this includes the testis, tunica, epididymis, and the good lengths of spermatic cord. Partial orchidectomy is done in specific circumstances, especially if the other test is removed, to preserve the endocrine and fertility function. There are other types like subcapsular orchidectomy, which is now rarely done. It was done in the past in the context of prostate cancer, and simple orchidectomy, which is done usually for benign diseases, including the testis, epididymis, and the very short lengths of the spermatic cord. The first thing in handling the specimen is proper orientation. So we identify the cord and the epididymis. The epididymis has bulbous head and the tapering tail. And in terms of inking, I usually don't ink testicular or orchidectomies unless there is a suspicion of tunica vaginalis invasion and adhesions, but this is not mandatory. For partial orchidectomies, we have to ink the resection margin. Moving to opening the specimen and fixation, the specimen should be properly fixed in neutral buffered formalin for at least 24 hours. This is of paramount importance to preserve the histology findings, which are crucial for the proper treatment of the patient, and also not only for tumor typing, but also for proper finding of prognostic factors like the presence or absence of lymphovascular invasion. This is done by, in radical orchidectomy specimens, this is done by opening the tunica vaginalis longitudinally along the lateral border, going toward the epididymis, making sure you do not completely bisect the hilar soft tissue at this stage. Just keep it intact until you take your proper sections. And this is the opening of the specimen is usually done by the pathologist, but if there is a risk of delay of transferring the specimen to the pathology lab, this can be done by the surgeons, but make sure that you will educate the surgeons how to bivalve the specimen in a proper way, not to distort or affect the assessment of the hilum. And this opening of the specimen may affect the assessment of the invasion, but this is a bit less important compared to the adverse effect of poor fixation with improper typing leading to improper treatment. For partial orchidectomies, there is no need for incision because the specimen is already smaller, and the formalin can penetrate the specimen or the tissue easily. And any incisions should be discouraged to avoid disruption of the resection margin. Quickly, as with other organs, we just measure the testis in 3 dimension and record the lengths of the spermatic cord. It's better on your cut-up or on your macro description. It's better not to use terms like proximal and distal, because this will be a bit confusing. Use cord. I mean, for the cord, you can use cord margin and cord base. That's much better. And then we should take the resection margin, the cord resection margin prior to incision of the tumor to avoid any contamination, which is commonly seen, especially with seminoma, because it's a very friable tumor. And then we open or reflect the tunica vaginalis to examine for any adhesions, which may suggest that there is invasion. And then we thinly slice the testis at 4 to 5 millimeters intervals, and the peripheral slices of the testis can be crocheted, which means like slicing the peripheral slices horizontally to more show the relation of the tumor to the surrounding tunica. For the tumor description and measurement, so we measure the largest dimension of the tumor. This is not important for staging, but it's just for documentation. And we have to record if the tumor is just a single tumor or there are multiple nodules, because this may indicate that there are different types of tumors. And if there are multiple tumors or multiple nodules, the largest nodule should be measured as well. In pure seminoma, the stage is affected a bit by the tumor size, especially in stage 1 disease, with a 3 centimeter size is cut off. That separates stage PT1A and PT1B. This is only in the AGCC staging, not in the UICC. And if we have multiple tumors in the setting of seminoma, this is measured as aggregates of tumor from one end of the tumor to the very other end of the satellite nodule, because this, if you think about the testis in this situation as showing a field effect with the background in situ and multiple invasive foci, so it makes more sense to measure the whole thing rather than just measuring the largest tumor focus. And the following pictures, in the following picture, I'll show some of the gross appearances of the common tumors in testis. So for seminoma, the seminoma are typically solid, well circumscribed, lobulated, homogeneous, pale gray to cream colored. They usually tend to replace the entire testis, and they show a soft or fleshy appearance. For the embryonal carcinoma, they tend to be more aggressive in appearance. They are irregular, poorly circumscribed, with a variegated cut surface. They may show areas of hemorrhage and necrosis. For the choriocarcinoma, so the left-hand side picture is for a pure choriocarcinoma, which is an extremely rare condition in testicular germ cell tumors. But if it is there is wide areas of necrosis and hemorrhage. And if it represents a mixed component or a component in a mixed germ cell tumor, as on the right-hand side picture, so the hemorrhagic foci represents the chorio component. Mixed germ cell tumors, they demonstrate a heterogeneous appearance, reflecting their composite nature. And in teratomas with somatic type malignancy, which are usually, or most commonly, they are soft tissue sarcomas, we see some fleshy whitish areas looking like a soft tissue sarcoma. In the setting of testicular scarring, which may represent a regressed germ cell tumor, the cut section shows fibrotic whitish irregular areas. And in sex-cord stromal tumors, they are usually small and well circumscribed. The Leydig cell tumors are usually yellowish and others are tan whitish. So for the sampling, we have to sample all grossly diverse areas. For tumors that are less than 2 centimeters, we have to embed the entire tumor. For tumors that are more than 2 centimeters, at least 1 to 2 blocks per centimeter from the largest tumor dimension should be taken, and sometimes we need to take more sections. It's a good practice to have at least one full face section having the entire testis with the surrounding tunica and including the hilum. If you have the facility of mega blocks, that would be better. If not, we can do it as composite blocks or composite slides as in the upper picture. And we have to take sections from the interface between the tumors and non-tumorous tissue along with the tunica, the surrounding tunica albuginea, and of course we have to sample the background testis, and we will discuss later why this is important. So do we need to do extensive sampling? The answer is in testicular tumors, yes. This is very important to identify and quantify the different tumor elements in mixed germ cell tumors, and to find lymphovascular invasion, which is a very important parameter in terms of staging prognosis. Can you unmute yourself? Mute yourself, please. Okay. So we do extensive sampling also in the scenarios of having a testicular scar, because this may represent a regressed germ cell tumor, and we may find some residual viable tumor within the scar. And as we said in the background, in a trial to find any germ cell neoplasia in situ. And also extensive sampling is recommended when the microscopic finding, as we mentioned, if they don't match with the macroscopic or the clinical impressions. And in tumors which are confined to the testis, it's important to extensively sample the tumor, because the stage may be upstaged, the tumor may be upstaged depending on the microscopic, depending solely on the microscopic findings, like the presence of lymphovascular invasion or microscopic invasion of the hilar soft tissue or the tunica. For the spermatic cord, we have to examine the cord for any gross abnormality. It's a good practice to take a section from the midcord, but it's not mandatory unless there is a gross abnormality. For the sake of number of blocks, this is not mandatory. And the extensive sampling of the spermatic cords is not necessary. Some people do this just in a trial to find lymphovascular invasion, but lymphovascular invasion is not seen solely. So if there is lymphovascular, if there is no lymphovascular invasion in the main tumor, this means that you will not find it in the cord. And take care that contamination of the spermatic cord by carryover of tumor fragments is very commonly seen, especially with seminoma. The testicular hilum should be also sampled because the invasion of retitestis, despite it's not changing the tumor stage, but it affects the prognosis and the treatment decision. And at least one block of the hilar soft tissue and the retitestis should be taken, but more sections may be needed if there is suspicion of invasion. And regarding the hilar soft tissue, it's very important to make sure where exactly did you take your section, because on the microscopic level, hilar soft tissue and spermatic cord they look alike because both have vessels and fat. So make sure that you know where exactly you took your section, because this may affect the staging if there is tumor invasion, because hilar soft tissue invasion is stage 2 and spermatic cord direct spermatic cord invasion is staged as stage 3. For the epididymis and tunica, they have to be examined for any gross abnormality, and they both should be sampled in all cases, even if they are grossly unremarkable. The tunica should be examined to identify any suspected foci of invasion, and if there is a grossly adherent tunica vaginalis, this may indicate that there is tumor invasion, but this could be because of other reasons like fibrosis and inflammation, but this should be sampled to confirm microscopically where is it invasion or not. So the background testis, at least one block of the background testis should be taken to identify the presence of Jicnis if they are present, because their presence is or absence is important in terms of subclassifying the tumors, because their presence is incompatible with the diagnosis of prepubertal types of germ cell tumors. And as we mentioned, they are very important. Their presence is very important in the scenario of testicular scarring, because they confirm that the scar we see is a regressed germ cell tumor, not just a traumatic process. So here is a summary of the macroscopic data items that should be included in our report: the size of the testis and the length of spermatic cord, adherence of tunica vaginalis, tumor location, the maximum tumor size, how the tumor look like, if the tumor is unifocal or multifocal, the relation of the tumor to the surrounding structures, the background, if there is any background abnormalities, and any spermatic cord abnormalities. So moving to the microscopic reporting, which should be accurate for diagnosis, prognosis, predictive, and staging purposes. And here is the latest classification of testicular tumors according to WHO 2022. And here is an algorithm of the germ cell tumors of the testis according to their origin, if they are related to Jicnis or not. We will not go in details in this slide because it's slightly out of the scope of our presentation. So regarding the microscopic description, it's very important to mention the percentage of different tumor elements in mixed germ cell tumors, especially the embryonal carcinoma, because it has a very important prognostic. It is a very important prognostic factor, and it's found that the tumors that contain 50 to 100% component of embryonal carcinoma, they are very liable for tumor relapse. And on the contrary, the absence of a component of yolk sac tumor carries an unfavorable prognosis. And the presence of a component of choriocarcinoma, whether mixed or in a pure form, carries a very, very aggressive behavior with early hematogenous spread to distant sites, especially lung and brain. In teratomas, there might be a somatic malignancy, which is a bit rare, but we see it. And this is defined as the presence of a pure population of malignant mesenchymal or epithelial cells that occupies at least one low power field, which is equivalent to 5 millimeter in diameter by the 4x objective lens. And rhabdomyosarcoma is the most common type of somatic malignancy, followed by the embryonic type neuroectodermal tumor, which was formerly known as PNET. Mentioning the somatic malignancy component is more important in the metastatic setting rather than the primary, because in the primary setting, all the patients will be treated as mixed germ cell tumors and they will behave almost the same. But in the metastatic setting, the presence of a somatic malignancy, this component will be chemo resistant, and will the prognosis will be a bit worse. Microscopic assessment of invasion of the tunica vaginalis. This is a very rare extratesticular extension route. It counts either the visceral or the parietal layers of the tunica vaginalis are involved. And if it is only identified on the microscopic level, there must be penetration of the tunica vaginalis, of the visceral tunica vaginalis mesothelial cells. So in the upper picture, we can see that the mesothelial cell layer is still intact, so this does not count as tunica vaginalis invasion. And in the lower one, there's disruption of this mesothelial cell layer, so this counts as tunica vaginalis invasion. So moving to one of the most important parameters in testicular tumors, which is the lymphovascular invasion. And it's very important, especially in the non-seminomatous germ cell tumors, because it's the most powerful prognostic factors for clinical stage 1 diseases. And it triggers adjuvant therapy rather than just surveillance. And it's less important in pure seminoma cases. So it should be reported if it is positive, if you are certain that there is lymphovascular invasion, this is reported as positive. If you are certain that there is no lymphovascular invasion, this is reported as negative. But if you are uncertain, don't say uncertain, say it as negative, because this may trigger the clinicians to treat the patient as having lymphovascular invasion with unnecessary treatment or over-treatment of the patient. And it's also not important to distinguish the invaded vascular spaces, lymphatic or a blood vessel. Both are okay, and we don't usually do immunostaining to confirm the presence of lymphovascular invasion. Because the problem is usually not is it a vessel or not. But it's whether is it artificial displacement or this is a genuine lymphovascular invasion. But sometimes we need to do these markers and take care that the CD34 stains the normal testicular stroma, so the background will be very messy, and you may overcall the presence of lymphovascular invasion. So I usually use ERG, which shows a clean nuclear staining of the vascular spaces. So lymphovascular space invasion is best seen at the periphery of the tumor and under the tunica albuginea. But even in the AJCC description, if there is a very obvious lymphovascular invasion that's seen within the tumor, this counts as lymphovascular invasion. And there are some famous pitfalls in identifying lymphovascular invasion, including the presence of histiocytes within the vessel lumen. And this can be easily identified by throwing some immunostaining. So in this case, these cells are positive for CD68, so confirming that they are histiocytes, they are not tumor cells. And on this one, the tumor, the atypical cells within the vessel are positive for OCT3, for confirming that they are tumor cells. And also the smearing effect and the implantational artifact from the adjacent from the tumor to the adjacent non-tumoral parenchyma, as we mentioned. This is very, very common in seminoma. It's a very, very good practice to mention which component of mixed germ cell tumor is showing lymphovascular invasion. What's within the vessels? Is it choreo? Is it embryonal carcinoma? This is important. There are some features listed on the Royal College datasets as features of true lymphovascular space invasion, which are the presence of a tumor group within a space, a lymphovascular or a vascular space that is lined by flat endothelium. And the tumor cluster may not conform to the exact shape of the vessel, and the presence of associated fibrinous thrombus, and the attachment to the wall of the vessel with re-endothelialization, which is a growth of endothelial cells over the tumor group within the vessel, and also the lack of the background artifactual deposition of germ cell tumor cells. And the tumor group within the vessel is very cohesive with rounded edges, like in this picture. Moving to the rete testis invasion, it's defined as the extension of the tumor into the mediastinum with or without involving the tubular lumina. So it is the stromal invasion, the invasion of the rete stroma that counts, not the pagetoid spread under the the epithelial lining of the rete testis spaces. This does not affect the stage. It's just a prognostic factor which predict the recurrence. And it's important to mention on your report which is invaded in this rete. Is it the stromal invasion, which is a core data item, or it's just a pagetoid spread under the surface epithelium? The invasion of the epididymis in the hilar soft tissue. This is an area of differences between the UICC and AGCC staging, as we will discuss later. Epididymal invasion without hilar soft tissue invasion is very, very unusual. The hilar soft tissue invasion is the most common route of extra-testicular extension, especially in germ cell tumors, and it's defined as the invasion of the adipose and loose fibrous connective tissue present in the hilar region beyond the boundaries of the rete testis between the rete and the epididymis. A quick slide about regressed germ cell tumors for the purpose of microscopic description. Having or seeing a scar within the testicular tissue, especially in patients with metastatic diseases but no clinically apparent tumor, this may represent a regressed or a burnt out germ cell tumor. There are some criteria that may help to distinguish, is this regressed germ cell tumor, or this is just a scar of trauma. These criteria, the established ones, are the presence of thickness in the background. This is the most diagnostic criteria, the presence of germ cell neoplasia in situ in the background testis, and the presence of coarse intratubular calcification, which represents dystrophic calcification in completely necrotic intratubular embryonal carcinoma. Some features are suspicious but not diagnostic criteria, like the presence of atrophic testis in the background, the microlysiasis, lymphoplasmacytic infiltrate, and predominance of vascularity in the scar tissue. And here is a summary of the microscopic data items, the tumor subtype, the percentage of tumor elements in mixed germ cell tumors, the maximum dimension of the tumor, invasion of the rete, hilar soft tissue, epididymis, and tunica vaginalis. These are all staged as stage 2, apart from the rete. This does not change the stage. Direct invasion of spermatic cord, the presence or absence of lymphovascular invasion, presence of invasion of scrotum if accessible, surgical resection margin in partial orchidectomies, and cord resection margin in radical orchidectomies, the presence or absence of background thickness, and the primary tumor stage, which is a T category. This is the AGCC 8th edition for the TNM staging of testicular tumors. And this is a very, very useful article about reporting and staging testicular germ cell tumors released by the ISUB in 2017. It has very, very illustrative pictures. It's very, very, very useful paper that I used to prepare this presentation. So, few comments on staging. Hilar soft tissue and epididymal invasion are now staged as stage 2, which is a change from the previous Royal College dataset edition, in which the epididymal invasion was regarded as stage 1 and hilar soft tissue was regarded as stage 3. So both now are stage 2. For the tunica vaginalis, it's very important to know that invasion of either layers, visceral or parietal, both count as stage 2. Lymphovascular invasion can be seen intraparenchymal, spermatic cord, tunica, and whatever the location, this is considered as stage 2. For the spermatic cord, it's a bit complex and tricky. So direct invasion to the spermatic cord, this is stage 3. If the tumor is seen invading or surrounding the vas deferens microscopically, this counts as stage 3 because this is a spermatic cord invasion, because the vas deferens is part of the spermatic cord. If there is spermatic cord lymphovascular invasion without involvement of the surrounding cord soft tissue, this is stage 2. And the presence of discontinuous soft tissue deposit of tumor within the spermatic cord, this counts as stage M1. This is according to the AGCC, which is not specified on the UICC staging. Combination of direct invasion and discontinuous focus, this counts as stage 3, PT3M1. And these are the differences between the UICC and the AGCC staging. So epididymal invasion on the UICC is 1, and stage 2 in the AGCC. Hilar soft tissue invasion is not considered in the UICC, but it's stage 2 in the AGCC. And the discontinuous involvement of spermatic cord is not considered in the UICC, but staged as M1 in the AGCC. And these are the references used to prepare this presentation. This is my last slide, and thank you.